Hi, my name is Brent Beasley, the medical director for St. Luke's Care, and today we have Greg Howell with us today. Greg is a pulmonary critical care physician. Critical care evidence-based practice team has created some new order sets for the health system to use that we thought might be valuable to go through and discuss, in addition to also discussing the recent literature that supports some of these endeavors. So Greg, welcome. We're glad you're able to be with us today.
Pleasure to be here.
Let's go ahead and get started. I want to start off quickly with mechanical ventilation. So a new order set that just passed by the St. Luke's Care evidence-based practice team. So the date on this that's come out is April 4th. And it kind of takes a physician in the critical care setting through just putting a patient on a basic ventilator. Greg, are there some things about this order set and or the recent literature that you wanted to kind of point out about mechanical ventilation?
Yeah, I think there's quite a few very interesting and very helpful things on this order set. First off, it really puts an emphasis on the very top of the page, and for instance, under ventilator settings, number 1, talking about more of a lung protective strategy of mechanical ventilation. Recently, there's been, lots and lots of data talking about, volutrauma and barotrauma, and there is a separation between those things. Volutrauma is it is a clinically significant problem that is independent of barotrauma. One would think intuitively that as volumes in the lungs go up, pressure in the lungs go up, and therefore volutrauma and barotrauma are identical. And actually, if volume or pressure is kept constant in the setting of a pressure controlled ventilation setting or APRV setting, we do find that patients are having injury from tidal volumes in and of themselves that are independent of pressure. So starting off with figuring out that we need people on 6 to 8 milliliters of tidal volume of ideal body weight is really important. The ideal body weight thing is actually very important because if you looked at even back at the ARDS-NET trial, one of the main criticisms, actually one of the criticisms that was published by another UMKC professor, Dr. Salzman, was that the ARDS-NET compared 6 milliliters to 12 milliliters of tidal volume. And Dr. Salzman's editorial in the New England Journal would have said that this trial is helpful, but not that helpful because we already knew 12 milliliters per kilogram would be injurious at the time that was done. But the ARDS-NET investigators had actually reviewed, broadly across the country what was being used, and when physicians thought that they were using 8 to 10 milliliters per kilogram, they were using actual body weight. Well, in our country, actual body weight is not usually consistent with ideal body weight. The obesity epidemic, etc., was showing that indeed at the time of the ARDS-NET trial, people were actually using 12 milliliters per kilogram of ideal body weight. So keeping tidal volumes in mind with ideal body weight, which is calculated by height, is the way to do it. As somebody gets heavier, their lungs shouldn't get bigger. So they won't get bigger, as a matter of fact. And using 6 to 8 kilograms of ideal body weight is very, very important. The respiratory treatments section, I routinely don't necessarily use bronchodilators on every single person, but as you know, the overwhelming majority of our patients will have some sort of smoking history where using either albuterol or a combination of albuterol and ipratropium will help not only with bronchospasm, but with mucociliary clearance. And then the other parts of it seem fairly straightforward, talking about ICU prophylaxis and monitoring with chest x-rays and blood gases, etc. I think it's a pretty solid order set. I think it's inclusive, and which is also very nice is it's only on one page, which makes it obviously much more user-friendly.
Greg, you mind talking just a little bit on, in the ICU setting, the DVT prophylaxis? Are there some issues that come up there particular to the ICU setting that a physician would want to stop and think about when they're using this particular order set? Right now, there's a DVT prophylaxis order set that this is bundled with, and so a physician getting that bundle, coming up with the DVT order set, looking at it, are some of the major issues that you're dealing with in the ICU about that?
The main things that we deal with are post-operative patients. When do we start ICU prophylaxis after somebody's had, a brain lesion or an abdominal issue or a thoracotomy, those types of things. As far as particular differences between one we use enoxaparin 40 milligrams once a day versus 30 milligrams twice a day versus heparin 5,000 units 3 times a day, a lot of that does come down to clinical practice, the particular clinician, what they feel more comfortable with. I am pretty comfortable with, I think that the enoxaparin, usually, I do believe that there's less heparin-induced thrombocytopenia associated with it. And the 30 milligrams twice a day is probably a little bit more valid in our morbidly obese patients. It's harder to get therapeutic levels in them when you're using subcutaneous. An interesting thing where some of these order sets are using heparin 5,000 Q8 hours. We recently had a Journal Club article where we were reviewing heparin 5,000 Q12 versus heparin 5,000 Q8 versus another one of the unfractionated heparins, and they found that the heparin 5,000 Q12 is probably as effective as Q8, so that might be something we can look at in the future.
That's great. The other thing that's come up recently is this issue about GI prophylaxis. So a lot of our ventilated patients need to be on GI prophylaxis. We also find that it doesn't get stopped once the patient comes off the ventilator and goes to the floor. So we find that we're spending a lot of money on GI prophylaxis that's not indicated. Your experience?
Mirrors exactly what you've just said. I mean, not only are patients going out of the ICU on GI prophylaxis, and usually a PPI, not an H2 blocker, which is even more expensive, but then they're even getting sent home on GI prophylaxis when they've never had any sort of peptic ulcer disease, gastroesophageal reflux disease, or any other indication for prophylaxis. So having some kind of stop triggers on these types of things, DC went off of mechanical ventilation, or reevaluate need for continuance after dismissal from the intensive care unit, I think it'd be helpful. In my eyes, the main areas where GI prophylaxis is indicated is active coronary disease in a mechanically ventilated patient, where they're on the ventilator for more than 24 hours. That's where our strongest evidence is for it. Past that, I totally agree with you that we are probably overusing it.
Okay, let's move on to the next one. This is the analgesia sedation orders for mechanically ventilated patients. Sometimes we're trying to get the patient off the ventilator, but they become very restless, they become very agitated, and so it almost seems like we're going to catch-22. We want to keep them sedated so they don't get agitated and restless. At the same time, we want to wake them up and get them off the ventilator. Can you, as you're going through that, kind of address that question as well as we're going through this order set?
This new order set, we've been using this, or an iteration of this, for a few months now, and I really think it's very good. I think addressing your first concern would be under Order 1A, where we actually are starting with, bolus doses, intermittent bolus doses of, the opioid analgesic, in this case, fentanyl or Dilaudid or morphine, Q30 minutes PRN for pain, and then similarly, we're using bolus doses to start off with Ativan or lorazepam as talking about addressing number 2. Oversedation in the intensive care unit is a big deal because it does lead to increased ventilator days, it increased ICU days, and then extrapolating from that, increased complications from being in the ICU, whether it's a ventilator-associated pneumonia, DVT, a stress ulcer, whatever complications come up. ICU delirium is a big deal. And ICU psychosis is what some people call it. And on this new protocol, we do use, under number 3, we are using the confusion assessment method, which is the CAM-ICU tool, where the ICU nurse will assess patients who are not overly sedated, where they have a RASS of -3 or greater. The nurse will then address the patient for delirium, running through a series of steps. When step 4 is found, this is manifest as disorganized thinking, where a patient is not able to answer simple, what we would consider common sense type questions. The patient is considered delirious, and at that point, that would be kind of a trigger to find some other type of method. Sometimes it would be something like haloperidol to help the patient, overcome their delirium and then make it easy for them to come off the ventilator. But I think the keys to this order set are starting with bolus dosing and, not having such a hair trigger on going to constant infusions, which can lead to over-sedation. The other important part is the sedation vacation, which is under number 3. Daily sedation vacations are shown to improve ICU length of stay, improve ventilator days, improve improve outcomes from an ICU psychosis standpoint. Having a daily scheduled sedation vacation, in my eyes, is for those reasons critical.
Great. Let's move on. The next one that we were going to look at is neuromuscular blocking agent orders. And this is one that has been worked on, has recently come out. And I have a question in my mind about when is the appropriate, when is this most appropriate to use on a patient. So we're trying to make sure our patients who are on the ventilator are completely immobile. So take us through when you would be thinking about this.
This is going to be very physician dependent, and you're asking me, so I'll give you my my take on this. Patients in the intensive care unit who we consider neuromuscular blockade are going to be patients who are refractory hypoxemia. Okay, so we have them on high PEEP assist control ventilation, or we have them on APRV, or even maybe on inverse ratio pressure control ventilation, and we're having trouble oxygenating the patient despite all of those measures. The patient's on 100% FiO2, et cetera. And now we've got to figure out a way to make sure that the patient isn't moving, is not using any extra oxygen or anything. The problem is that those patients, that population of patients, is going to have a very high incidence of concomitant steroid use. So, these are going to be ARDS patients who may be in the fibroproliferative phase, or they're going to be somebody who has acute interstitial pneumonia, or a horrible eosinophilic pneumonia, or post-influenza, ARDS or acute lung injury, all of which steroids are going to be considered for, and a lot of times are going to be used for. And the problem with using steroids in conjunction with neuromuscular blockers is that the risk for ICU polyneuropathy with that combination is multiplicative. Similarly to asbestos and smoking, that's not an additive risk for lung cancer, that's a multiplicative risk for lung cancer. Similarly with neuromuscular blockade, whether it's a depolarizing agent or a non-depolarizing agent, those will increase the risk of ICU polyneuropathy. For the patient, that's a huge deal, because that can end up being a several-month course on the ventilator, very, very difficult to wean, takes a long time for the patient to get off. Now, despite that, there are going to be times when we do need to use neuromuscular blocking agents. Despite having the patient on very huge doses, for instance, 20, 30, 40 milligrams of midazolam an hour with 300 micrograms of fentanyl an hour, the patient's still hypoxemic, and we simply can't get them to stop moving without that. That would be an instance where we have to use it. If the patient's on the oscillator, we're going to have to have them paralyzed. A lot of times to initiate ECMO, they're going to need to be paralyzed. So the need for an order set is very, very important, and this order set is very well thought out. It talks about both the initiation and the withdrawal of the neuromuscular blocking agent, and it talks about the importance of making sure that the patient's eyes are protected, and the increased risk for decubitus ulcers in an entirely immobilized patient. Now, I've gone through all of the horrors of ICU polyneuropathy with neuromuscular blocking agents. Recently, we did review an article showing safety in its use in the intensive care unit setting in early ARDS, which was a big surprise. Even though in the past we've always thought about these huge risks and therefore been very, very stingy with neuromuscular blockade in the medical intensive care unit setting, there was a recent study published showing safety of, as I recall, cisatracurium in the ICU setting despite large doses of steroids. Patients actually, although it was a trend, it actually seemed like patients might have been able to get off of the ventilator a little bit sooner if they had a neuromuscular blockade in small doses early on. Interesting.
Greg, that kind of leads us into this next order set. It has to do with ARDS and mechanical ventilation in ARDS. When you began our discussion, you were talking about tidal volumes and talking about barotrauma and volume trauma. So take us through this with that in mind as well, because I know that that's one of the main things that this is trying to attack is preventing the barotrauma.
This is incredibly important, in my opinion, for any ICU in any health system to have, is a good protocol for treating ARDS. ARDS is very common just because sepsis is very common, aspiration is very common, pancreatitis is very common, and we take care of a lot of ARDS patients in any one given week that we're on the unit taking care of patients. This all began, as you know, with the ARDSnet trial, and this trial, despite some of the flaws that we were talking about earlier with comparing 12 to 6, and we don't know if 6 cc's is better than 5 cc's, we don't know if 6 cc's is better than 7 cc's, all we know is that 6 cc's is better than 12 cc's. Nonetheless, 12 cc's was the standard at the time, and I do believe that. And 6 cc's was shown to have a dramatic improvement in patients' survival. The number needed to treat in order to save one life using this strategy is only 6, and this doesn't cost anything. I mean, this is different ventilator settings is all we're talking about here. And I think there's several things that are important to know that we need to keep in mind when we're running what we call the ARDSnet protocol. First off, their numbers are not going to be as good. Patients in the low tidal volume group in the ARDSnet study had lower oxygen levels, had higher CO2 levels, had lower pH levels, but importantly, they had higher survival levels, and it wasn't a close call on this. And so it kind of goes back to one of those things that we see in medicine come up from time to time. Taking abnormal numbers and making them normal is not always necessarily the exact right thing to do. What we'll do in the ARDSnet protocol is we'll tolerate PO2's oxygenation, a PO2 of 55 to 80, lower than what some clinicians are used to. Oxygen saturations of 88 to 95% instead of the older standard of keep oxygen saturation 92% or greater or 94% or greater. Just because their numbers look worse initially in the ventilator course, and those numbers do look worse because your mean airway pressures are lower with lower tidal volumes, those numbers, those worsening ABG numbers, if you will, do not portend a worsening, but rather portend, in this case, improved prognosis. So that's one thing that physicians do need to realize is that pHs are going to be lower, CO2s are going to be higher, PO2s are going to be lower, but more of our patients are going to live on this type of a protocol. The other thing that's very, very important to stress, especially in an obese population, is that these tidal volumes are based on ideal body weight or predicted body weight, not actual body weight. So if you have a person who's 6 foot tall and 350 pounds, that doesn't mean that they're going to get, 6 cc's per kilogram at 350 pounds, rather 6 cc's per kilo of their predicted body weight. And attached to this order set is the predicted body weight for patients, for males and females of very broad height.
Okay. In terms of when you're putting someone on this ARDS protocol, let's say, when are you deciding to use this? You had them. I'm guessing perhaps that some of these patients come in. You actually have them on the routine mechanical ventilator order set. When does the pulmonary critical care doc say, okay, we need to really move to this ARDS protocol with much lower pressures and things like that?
The move is typically made anytime the diagnosis of ARDS is made. And so if somebody started off with an aspiration, they have a unilateral infiltrate, and they're in the intensive care unit, and then they move, indicators that somebody's moving toward ARDS would be the following: worsening oxygenation. The definition of ARDS from an oxygenation standpoint would be a PF ratio of less than 200. PF ratio is the PaO2, the arterial PO2 on the ABG, divided by the FiO2. For instance, if somebody has a PO2 of 100 while on 50%, which would be 0.5, that would be a PF ratio of 200. So that's one of the first indicators that ARDS may be coming on as worsening oxygenation, manifest by that lowering PF ratio. The next is a 5-lobe alveolar infiltrate. So Something that would go against ARDS would be a unilateral, right lower lobe infiltrate from community-acquired pneumonia. Somebody could easily have a PF ratio of less than 200, but that could be explained by their pneumonia and not by ARDS. So ARDS, by definition, is a diffuse alveolar infiltrate involving all of the lungs. And then the final key to that is more than one thing can cause diffuse alveolar infiltrate in all of the lungs, and one of the huge contributors to that can be increased, left atrial pressure, meaning somebody's in either systolic or diastolic heart failure. So before the diagnosis of ARDS is made, your estimate of left atrial pressure, whether that's by echocardiogram, checking a serum BNP, physical exam, right heart catheterization, whatever the case is, you got to make sure that you're not calling acute heart failure ARDS. But once those criteria are met, number 1, PF ratio less than 200, number 2, 5 lobe alveolar infiltrate, number 3, a normal left atrial pressure, then the diagnosis of ARDS is made, and we should be transitioning to lower tidal volumes.
And it also moves us to this box over here, which is where we're considering ECMO consult. And I do think it's really valuable. The St. Louis Health System has ECMO as an opportunity for our patients.
Mm-hmm.
I know that you've probably seen some cases where an ARDS patient went to ECMO and actually eventually lived to tell about it.
Mm-hmm.
And perhaps you could tell us about that. And take us through, this issue about when you decide you're going to call. Michelle Haynes, I think, is the medical director for ECMO,
Mm-hmm.
and when you're going to give Michelle a call. The numbers here on the order set to try to be thinking about ECMO. And this would be for any of our hospitals in the health system. If we've got a patient on the ventilator, obviously the EICU doctor may be helping to make that call, but if any physician in our health system that's got a patient on the ventilator can be looking at their patient and deciding, should we make that call for ECMO?
ECMO is an invaluable tool, and we have met with a lot of success in our ECMO patients. The times when the phone is ringing from my standpoint to call Dr. Haynes would be in a patient with, that we are seeing very rapid deterioration in oxygenation and failing to be able to keep up with it with conventional ventilation. Most recently, there was a 40-year-old plus or minus female who was admitted to the hospital after 3 days of worsening dyspnea. She was then followed a course of requiring 2 liters, then 4 liters, and then 50%, and 100% non-rebreather. Then we find her on the ventilator within about 3 days of her hospitalization, and you could just see a rapidly progressing disease process moving forward in her. In her case, it was acute interstitial pneumonia. She was put on the ventilator and pretty refractory to elevated levels of PEEP. She was on 20, 22 a PEEP, 100% FiO2, and I felt at that point that, in order to get oxygen into this lady's blood, we were going to have to do something, more drastic. And this was very early on in the course. So important things to consider for ECMO is, number 1, you got to have some hope that the patient's going to survive. You don't want to take somebody with a dismal prognosis and then go forth with running through ECMO and everything like that, because if somebody has no chance of survival from their disease process, then that exercise should not be undertaken. The next thing is the patient should not be on the ventilator for more than 7 days. The infection risk, and that's one of the exclusion criterion, as a matter of fact, for going on to ECMO. And the third thing, I think that some of it's just how sick the patient is and how fast they're getting there. It just seemed like the freight train was going in one direction on this gal and needed to be, changed. And early steroids in this case were not, in my opinion, going to do it. Antibiotics up to this point in the patient's hospital stay had not done it, and there was zero indication that there was a cardiac component to this. So this was a disease process that clearly was going to have to run its course. And the question was then, were we going to do an oscillator? Were we going to do ECMO? Were we going to do conventional ventilation? So we consulted the ECMO team, and initially oscillatory ventilation was tried in the CVICU, but similar results were experienced, so the patient was transferred to ECMO the next day. The take home on this would be a rapidly progressive hypoxemic illness. A lot of times that could be ARDS, acute interstitial pneumonia, and then when the H1N1 epidemic was around, that was a huge benefit of having ECMO, because this would take young, otherwise virile patients and giving them a bridge to allow the disease process to run its course and then get the patient back to normal.
ECMO meaning extracorporeal membrane oxygenation. So,
Correct.
And can you tell us what severe air leak syndrome would be in a situation? That was another criteria that they mentioned on here, and I wasn't exactly certain what that would be applied to.
Severe air leak syndromes would be where a patient has barotrauma.
Okay.
And barotrauma or volutrauma indicating a bronchopleural fistula that is not closing.
Greg, we really appreciate you taking time for us today and taking time to take us through these order sets. They're online. They're available to the clinicians to use. Please take some time to review these, and thank you for your time.